All right, so my name's Kylie. So I have met a few people around over the weekend. I am a physiotherapist based in Berrima at Tangibilis Physiotherapy, and I've been a physiotherapist now for 10 years, and I've predominantly worked in musculoskeletal sports physio and occupational health. Started looking for a bit more of a challenge, so started to work in women's health a bit, and then I was approached by some urologists probably about 2 years ago now, asking if I could do some males pelvic health and physiotherapy, and I thought, well, why not? There's no one else in Darwin that really works in this area. And I felt like, well, why is it that women can have all this help, but the services are lacking for men? So I figured that it was something that I could sort of work my way into, and I actually quite enjoy. Like 10 years ago, I never would have thought that it would be an area that I would choose to go down. But I'm actually glad that I have, because the men are generally quite enjoyable to work with once you build the relationship and trust with them as well. And just what I find with men is that, they like to learn and understand, and once you give them that little bit of education, that, they tend to take everything on board, and, they really want to do what they can to help themselves, particularly when it comes to pelvic health as well. So the aim of today and what you're going to learn about is the male pelvic floor. And yes, men do have a pelvic floor. A lot of men do not know that or do not realise. And just like women, men can have a pelvic floor dysfunction as well. So a lot of the guys that come in, tend to say, oh no, I didn't know I had a pelvic floor. I thought only women had them, and I only know about that because my wife had a baby. So I think it is something that's not often spoken about, and it's definitely not spoken about enough. Pelvic floor dysfunction and management we'll talk about. I'm going to talk about erections, how they work, just in very simple terminology. Don't want to go too deep into all of that stuff because, we just want to know that we can do it. The causes of erectile dysfunction and management options for that as well. And we will talk a little bit about general health as well. And I've got some resources that, you can go away and look up as well. So some stats and facts to begin with. So the leading cause of death in men is coronary artery disease. You will, as we go along, you'll realise why I start to talk a bit more about general health and cardiovascular disease as well. And this is the reason why I'm talking about erectile dysfunction, because I think it's a good avenue to start talking about general health in men as well. Erectile dysfunction is associated with an increase in heart attacks, strokes and cardiovascular death. 1 in 4 men under 40 will seek medical help for erectile dysfunction. So I think this stat is quite good to indicate that it just does not happen to older people. And I think, that's what a lot of people seem to think, is that, if you're over 50, oh, it's happening because I'm old. It doesn't happen because you're old. It can happen to anyone at any age. Losing 5 to 10% of your body weight can improve sexual function. Your penis is twice as long as what you think. So more than half of your penis is actually housed inside your body. Your penis is born ready. So, quite often as the baby is born or a male is born, they will be born with an erection. And, they occur in the womb as well. And having more orgasms may help you live a longer life as well. And I think the gynecologist yesterday afternoon touched on some of this stuff as well. And sitting there listening to her, I thought, I actually like the fact that there's a bit of crossover with all of this stuff as well. So just the pelvic floor, male pelvic floor in a nutshell. For the purpose of today, I won't talk about them in like the proper anatomical terms. Maybe in some parts I will, but in a nutshell, you've got a superficial pelvic floor and a deep pelvic floor. So the superficial pelvic floor is the ischiocavernosus and the bulbospongiosus or the bulbocavernosus. So those words or names are used interchangeably. and the deep pelvic floor muscles, collectively they're called the levator ani. And so there's 3 of those muscles that create the levator ani. So the ischiocavernosus and the bulbospongiosus are, these muscles along, I guess, the shaft of the penis, and then the levator ani is the main one that you see, forming the sling. I will pass this around, so it's a very basic drawing of the pelvic floor, but it gives you an indication of, sort of looking at it. So you've got the tailbone at the back, the pubic bone at the front, but it gives you a little bit more understanding that it's not just one muscle that supports the pelvic organs. And I think in both men and women that, quite often, because we see pictures like this, we feel like, or people think that it's like a hammock or just one muscle. So, and then you've got your muscles on the outside as well. Okay, so the functions of the pelvic floor. So just as with the female as well, so you've got pelvic organ support. So it provides support for the bladder. The prostate is the orange nut, I guess you'd say, under the bladder, and the bowels. So it supports so that the organs aren't going to, fall down through the pelvic cavity. It helps with bladder and bowel control. So both the urethra, which is the yellow bit coming from the bladder, and the anus have their own internal sphincter, which close off automatically without us thinking about it. But sometimes that sphincter is not strong enough, and the pelvic floor provides that external support to reinforce it as such. So when we talk about any incontinence, it is any involuntary loss of urine, faeces, or flatus or passing wind. So any of that is incontinence. Even if it's, for men, a couple of dribbles, you've been to the toilet, you walk away and you have a couple of drops afterwards, that's still classified as incontinence. So it would be referred to as an after dribble. And the pelvic floor muscles helps with or assist with sexual function as well. So it helps maintain and gain an erection. So the pelvic floor muscles on their own won't get the erection or maintain it, but they definitely assist in maintaining and achieving the erection. So the pelvic floor muscles can be weak, tight, or they just don't coordinate well together. Okay, so what can cause pelvic floor dysfunction? So you've got pelvic surgery. So the main one would be the prostatectomy. So if you think about where the prostate was in relation to the urethra, when we remove the prostate, it will have a huge impact on the urethra and the function or the control of the urethra and the pelvic floor. Straining to open your bowels, so any forceful movement where you're pushing down to go to the toilet can cause dysfunction to the pelvic floor because you're increasing that intra-abdominal pressure. And we also need to know how to relax the pelvic floors to allow a complete emptying of the bowels or the bladder. Lack of exercise can cause pelvic floor dysfunction. So just like any muscle in our body, we need exercise to help maintain tone. And we go to the gym to keep our other muscles healthy. So why don't we keep our pelvic floor healthy? Being overweight, so that's a big thing as well, increases abdominal pressure, intra-abdominal pressure, and it bears more weight down onto that pelvic floor. Having a chronic cough or a persistent cough, all of these come down to intra-abdominal pressure and putting more force on the pelvic floor, and repeated heavy lifting. So if you're constantly lifting heavy weights, there's nothing wrong with lifting heavy weights, but you need to be able to breathe and not hold your breath while you're doing it, because it's that breath holding and that straining as you do it that's going to create a dysfunction. Okay, so pelvic floor dysfunction. So a pelvic floor dysfunction is classified as Well, it's the inability to control your pelvic floor muscles. So as I said before, the muscles can be weak, they can be tight, or they just don't coordinate well together. So you're not getting, so if you're going to the toilet, to open your bowels, you're not able to relax those muscles to allow the bowel movement to happen. And that's where your straining will happen. So it can result in stress urinary incontinence. So stress urinary incontinence is, any leakage associated with a cough, sneeze, running, something that's high impact. Frequency, so going to the toilet on a more regular basis. So with a healthy pelvic floor, you would generally, and not just with pelvic floor, so healthy bladder and bowels, you would go to the toilet on average 4 to 6 times per day, and no more than once per night would be classified as normal. Anything more than that, there's something going on, and it would be identified that you've got some form of frequency. Urgency, so I'm pretty sure everyone in this room has had some form of urgency before, and urgency is generally associated with some form of trigger. So it could be, you get home from being out at the shops and you get to your front door and all of a sudden you've got this overwhelming sense of, I've got to get to the toilet, and if I don't go, I'm going to wet myself. So that's what is classified as urgency. The inability to control flatulence, so passing wind. So in older gentlemen, you're probably more likely to see this when, they're getting up from sitting to standing, and that change in intra-abdominal pressure where, they can't control the wind and they'll pass some form of wind. I'm sure you've probably seen that with your grandpa at some point. And if you're working in a hospital setting, it's really common as well. And after dribble, so as I mentioned before, the after dribble is, you've gone to the toilet, you've had a little shake to clear everything, but as you walk away, you get a couple of little drops. And if we think about the plumbing of the penis and the bladder and the urethra, you've almost got like this S-bend. So, there's, at the bottom of that S-bend, you're getting a little bit of urine that's staying there, and then as you drop down, so as it drops down, you'll get a little bit of leakage. So a quick tip there is to, if that's something that you get, you can place some pressure on the perineum and drag that forwards and bring it forwards, and then have a shake out. So go to the toilet as you normally would, shake it out, and then place some pressure on the perineum and drag it forward. So that can be referred to as milking the urethra as well.
But I didn't learn that until I was 33. I read Steve Biddulph's book.
Yeah.
He was talking about men and urinals and all of that sort of stuff. Anyone who's read that book on masculinity and sexuality and mental health. But I just wanted to say that the way I was taught to pee as a child did not hold me in good stead for later on.
Yeah. And actually, interesting that you say that too, because some of the guys that I have seen, a lot of the habits, I guess, that they have, or the dysfunction that they have, has been set up in their early years of life. So even to the point where they're pushing their urine out to empty their bladder, and it's retraining all of that and changing these habits, because they're not things that have just happened overnight sometimes. So. And I've learnt all of this as I've gone along, treating men as well. So as a female, yes, we've got similar muscles, and we've still got the pelvic floor, but my experience as a female is obviously a whole lot different to what it is as a male. So I learn a lot from my patients as well, and particularly when it comes to cues and tips on how to actually do your pelvic floor exercises as well. So I never underestimate my patients, because I learn a lot. So the managements of pelvic floor dysfunction. So once again, it depends on the primary type and the cause of the dysfunction as well. So if you've got urgency, the pelvic floor exercises are important, and we'll get to the point where I talk to you about how you do your pelvic floor exercises. So as I said earlier, the external muscles, or not the external muscles, but those deep pelvic floor muscles and the superficial muscles reinforce that internal sphincter to allow to get more closed pressure around the urethra or the anus. You've got bladder retraining, so for something like the urgency, you're identifying the triggers and going, okay, it's when I get home from the shops, it's opening that door where I get that sense that I'm going to wet myself and I really need to run to the toilet. So once we've identified that trigger, rather than taking yourself straight off to the toilet and going to the toilet, which is almost positive reinforcement for the brain, you're giving into it. So the bladder itself is a muscle, and it's so easily to train and to train bad habits as well. So you need to break that cycle. So even if it's like that you're going to get that sense of urgency, what can I do to stop it? Can I delay it by at least 20 seconds before I give in and then actually go to the toilet? And once that 20 seconds has passed, do I still actually need to go to the toilet? Sometimes you don't. And a few little tips with that, and this works for females as well, is applying some pressure, firm pressure to that pubic bone, or also going up, up on your toes. In an airport, it's quite common to go into a female toilet and you'll see women, doing this, or they're standing there with their legs crossed. And it's a distraction technique, but the pressure on that pubic bone and going up and down on your toes uses the same nerve supply as what the bladder uses. So that's why they do work. I see it a lot. Like I do a lot of running, and I'll see a friend stop for a drink, but all of a sudden they've got to tie up their shoelace, and you can see that they're down in this position and they've got their heel sitting right on that pubic bone. And with my background, I'm like, I know what you're doing. But they're very handy tips to have. And if you work in an office or something like that, what you'll find is, because young kids, you see them running around holding themselves all the time. But as an adult, sitting on the corner of the table could be an option, because that pressure at the table will provide, that same form of pressure to the pubic bone. And then you've also got medications to help with urgency, and that will just stop or delay or lessen involuntary contractions of the bladder. I'm not going to go into medications, that's not my scope, so I'm just going to leave that as it is. Stress incontinence, so same thing, you've got your pelvic floor exercises for that, works in the same way as what it does for the urgency. Urethral bulking agent, so that's an injection of a synthetic product into the penis, which will narrow the urethra, which will slow down the leaking as well. Once again, not my area, it's something that the GP or generally the urologist would recommend or advise, but I could guarantee that they would send you to a physio before they go down that path. And there's also surgery that can be done. So similar to a female, you can get a sling surgery, which will support the urethra, or they can put an artificial sphincter into the urethra, and you've got control over opening that up and closing it off. I haven't seen anyone with that done before. I don't know how regularly they are done, but I just know that it's an option there. So, yeah. So how do we find the pelvic floor muscle? So basically it lies between the tailbone and the pubic bone. So as you see in the picture. So some of the cues that I use for the men is, or even females, is I'll start with, if you think about your muscle in between the pubic bone and the tailbone, can you squeeze and lift that muscle? Quite often the men will sit there and go, I've got no idea what you're talking about. So then my next cue will be, can you shorten your penis? And they'll sit there, they'll look at me and they're like, oh, yeah, I think I am, I'm not too sure. And because you want to try and give them the chance to try and figure it out for themselves before you just get in there and tell them how to do it. I love it when the girls come in, or the women or the men come in, and I'm doing this sort of stuff with them, because I get my pelvic floor exercises done all the time, because I feel like the moment you start talking about it, you think, oh yeah, I can do it, like it, yeah. So I find that works the best for me. So well, with my patients, I should say. So if they can't do it sitting, I get them to try it in standing, I get them to try it laying down. So you should be able to do it in all different positions. You should be able to do it while you're walking as well. If people are really struggling, in the clinic we can use ultrasound to try and give some visual feedback, and that way we can see if they're actually doing it as well. But you can always place your hand on the perineum to feel that lift or that contraction, or the other option would be to use a mirror. So you can either stand face onto the mirror and you should see a little lift in the penis, or otherwise you can pop the mirror underneath and you can see the contraction through the perineum as well. Some of the other tips that guys have said to me, or patients I should say have said to me, is that, you know, oh, you could say if you're standing there and you want to imagine peeing over a fence but you can't use your hands, and so you're trying to get that lift with your penis as well. So that's a cue that a patient has given me before as well. So you can, pelvic floor exercises you can do, as with, I don't know if you sat in on Clee's talk yesterday with the women's health stuff, but you can do like the quick squeezes, so you're just coming onto a contraction, back off, so it's just on, off, or you can do the contractions where you hold for a period of 10, 20 seconds, 30 seconds even. You need a mix of both those quick contractions, and also you need to be able to hold the contractions as well. So you're almost building power and endurance with it as well. When you're doing it, you don't want every other muscle to be contracting. You don't want to be holding your breath. So you should be able to have a conversation and still be able to do it. You should be able to do it without anyone knowing that's what you're doing. So erections, how do they work? An erection is the ability to obtain and maintain an erection for penetration and for the duration of satisfactory intercourse. So that's what you would classify as a normal erection. Erections, they're quite complex. So it's a complex interchange between the brain, the nerves, the blood vessels, the muscles, everything's got to work together. So obviously there's got to be some sort of stimulation to start off with. So whether or not that's through touch, through the mind, watching something, however you get your stimulation, then you're going to get the sensory feedback to the brain. The brain's going to send signals. You're going to get blood flow to the penis. And then you get contraction of the penis, and I'll get into that in a minute. You'll get a contraction of the penis, the pelvic floor, which will hold the pressure within the penis. And then when you're not aroused anymore, the reverse will all happen and the penis will go down. So the triggers can be direct or indirect. So when we talk about triggers of stimulation, direct would be direct contact, or, you're touching something. Indirect is, thinking about, fantasy, something that you hear, you smell, you see. So as I said before, the nerves will release the chemicals which increases the blood flow to the penis, and the increase in the blood pressure chambers is what makes the penis firm. So these two pictures they're a cross section of a penis. So obviously this one on your left is a non-erect penis. This one on this side is an erect penis. So the penis is made up of 3 chambers pretty much. So you've got the corpus spongiosum, which is this bit around here, and that wraps around the urethra, and that controls the diameter or the dilation of the urethra, and as to whether or not urine or semen's going through. You should not have urine in your semen, so you can't urinate and ejaculate at the same time. And then you've got the corpus cavernosum, which are the two larger chambers. So what will happen is that the corpus cavernosum, so it's just like lots of different fibres. I'm not going to call it a muscle because it's not really a muscle. Lots of different chambers. When the penis is flaccid or not erect, those chambers will be in somewhat of a contracted state to decrease the blood flow into the penis. So that's why the penis is flaccid or soft. As you become aroused, those chambers will dilate, which will allow the blood flow in, which will then create firmness in the penis or the erection. They will then close off when the blood is in there. The pelvic floor will start to enact, and they will also make like a hydraulic pressure as well. It's pretty much a hydraulic system. So the pelvic floor will sort of sustain that pressure in there as well. So yeah, the penile erection requires the presence of a pressurised and closed hydraulic system within the corpus cavernosa, which are the two larger chambers. So the ischiocavernosus, so that's one of the superficial pelvic floor muscles, will compress the roots of the corpus cavernosa, which increases the blood pressure within the penis. And the bulbospongiosus, which is the other superficial muscle. This is the only time I'm going to use the terminology of the muscles, will lead to engorgement of the glans penis, which is the tip of the penis, and the corpus spongiosum will also increase the pressures. So that's how that works. Those muscles will give, as I said, when you contract them, they will give that little lift to the penis as well. So it changes the angle of the penis. So types of erections. So there's 3 types of erections. So you've got the reflexogenic erections. So that's a response to tactile stimulation. So any form of touch, sexual interaction. Psychogenic erection, so that's in response to fantasy or visual stimulation. And then you've got nocturnal erections, which can also be called, some people might call them housekeeping erections. So they will occur during your deep sleep. You'll generally have 4 to 6 of these erections per night. And they're actually quite important because during that time, you're getting an increase in blood flow and oxygen to the penis, and it's the blood flow and the oxygen that keeps the tissues of the penis healthy. So if you do notice that you're not getting these erections, or you're not waking up with an erection, or you've lost any form of an erection, you should actually go get that checked, because we do want to maintain the blood flow to the penis as much as we can to maintain the integrity of the tissue. Any loss of erection can be a sign of any sort of cardiovascular disease. So this is why it's important, and you should, seek help from a GP, if it's something that you have noticed as well. So causes of erectile dysfunction. So there's lots of different causes. Psychosocial, so that can be anything from performance anxiety, your relationship pressures, loss of employment, financial stresses, like anything that can have some form of stress in your life or impact in your life can cause erectile dysfunction. Interference with nerve function, so that's pretty much a physical thing. So anyone that's had a spinal cord injury, multiple sclerosis, so generally some sort of chronic condition will cause this type of erectile dysfunction or cause an erectile dysfunction. Reduced blood flow, so cardiovascular disease, type 2 diabetes will have an impact as well. Drugs, alcohol and medication, so any type of drug or alcohol abuse can have an impact on the erectile function. And in saying that, with medications as well, there's some medications that people can take for diabetes, blood pressure or hypertension that can actually have an impact on the erectile function as well. Metabolic problems, so that's obesity, type 2 diabetes, cardiovascular disease, and any sort of urological or endocrine problems, so prostate cancer or something like that. So there's lots of different factors that can cause it, and it's identifying what those factors, when you're treating erectile dysfunction, it's identifying any of these other things happening that could be having an impact on it, or is it actually just a physical issue with the pelvic floor. So the pelvic floor and sexual function. So sexual functions, obviously, it's essential to good health and well-being for both men and women. So we want to make sure that we can stay sexually active in some form or other. So the relationship between male sexual function, pelvic floor function and pain is actually quite complex, and it's only just now that it's starting to become more appreciated, and more and more research is starting to happen with that. I think it's been a long time coming, and we've put a lot of effort into probably women's pelvic health to start off with, and now men's pelvic health is coming more to the forefront as well. Pelvic floor muscles are important for sexual stimulation and orgasm. So basically the pelvic floor muscles can increase the ejaculation and the force of the ejaculation as well. So that pretty much says the same thing. So let's get intimate. So orgasms, lots of different benefits from having an orgasm or achieving an orgasm. So first and foremost, it's a pelvic floor muscle workout. So when you orgasm, you get a rhythmic contraction through the pelvic floor. Both men and women will. Pretty much a car wash for the pelvic floor, so lots of different fluids going in and out. You would have heard that the vagina is self-cleansing. Likewise, it's healthy for the penis because you're getting increased blood flow and things like that as well. Improves our mood. You get a bit of a butt workout, you get a heart workout. It helps you sleep, improves intimacy, and reduces stress. The important thing to note here is that to achieve an orgasm, you do not have to have an erection, and you do not have to ejaculate. So a lot of times men will think that because they haven't ejaculated that they haven't reached climax, but you don't need to ejaculate to reach that climax. And in fact, people that have had a prostatectomy or had their prostate removed will not ejaculate because they've lost that function as well. Which, I think, I don't know, obviously being a man, I'm not sure how that affects, the way you feel about it and what you've achieved by not ejaculating.
I had prostate cancer with external radiation.
Yeah.
Without the hormone treatment.
Yeah.
Which lowers the testosterone
Yeah.
level, which increases the cancer.
Yeah.
And everything's in fine working order.
Yeah. Including the ejaculation.
But
No.
as far as ejaculation, no.
Yeah.
What
Yeah.
comes is just very minimal now.
Yeah. Yeah. And, and I think that's the thing. So when people come in post prostate surgery, they, what about my sexual function? How's this going to affect me? And I think sometimes people or the doctors forget to mention that they will end up having a dry ejaculation, so it comes as a bit of a shock. So it's always something that I make sure that I do mention to my patients so that they are aware of that as well. Management options for erectile dysfunction. So as we say with anything, use it or lose it. So whether or not you can achieve a full erection, whether or not you can ejaculate, anything that an erect penis can do, a flaccid penis can do, apart from penetration. So, I think that's important to note is that, you can still do whatever it is that turns you on or arouses you. You've just got to be a bit more open-minded and, sort of open up your mind as to what you actually think sex is or what sex means to you, you know. And the more that you can play around and find different positions or, you know, different ways to pleasure yourself or your partner to pleasure you, the better it's going to be. So even though you can't achieve the erection, there's no harm in trying to, because as I said, it's going to increase the blood flow to the area, which is going to help maintain a healthy tissue of the penis. Pelvic floor muscle training and relaxation. So I put relaxation in there as well, because sometimes too, if people have a high resting tone of their pelvic floor, it will prevent blood flow from going into the penis. So the best, you need to, if there's an erectile dysfunction, is it because the pelvic floor muscles are weak? Generally, there's lots of other factors going on. It will never just be the pelvic floor with erectile dysfunction. But, you know, yeah, is it because they're weak, or is it because I'm too tight through the pelvic floor muscles, or I can't relax them, that it's not allowing for that blood flow? The only way, you know, you're going to be able to know which one it is, you know, seeing probably a physio, you know, to try and work out which one it is for you. Medication, so lots of different medications that you can use. So the most common medication would be Viagra or Cialis. The gynecologist spoke about them yesterday afternoon as well. You still need stimulation if you're taking those medications, and medications are important, particularly if you've had some form of pelvic surgery and things like that. I've had guys that come in and go, oh, they've put me on Viagra, but I'm not taking it. I'm not sexually active anyway, so it doesn't really matter. And I'm like, it's not just about being sexually active, it's about keeping blood flow to that area and keeping the tissues healthy.
What about the penile injections?
Yeah, so you've got the penile injections as well. So they, I think that could be my next one. Yeah.
Sorry.
You're all right. So you've got the penile injections as well. So the erections happen, I think, within 10 minutes or so of injecting. You don't need any stimulation for that, so that they will just occur. You still need some?
If there is stimulation, it just makes the erection.
Well, and I feel like it's better if you have some sort of stimulation anyway. Like, you know, you don't want to just inject yourself and do nothing with it. Like, you've got to be able to enjoy it as well, don't you?
And it's funny how guys go, no, I'm not going to stick a needle in my dick.
I know.
I've done it, and it just isn't needed.
Yeah, and I think too, when it comes down to medication and penile injections, that the education's got to be there as to why you're doing it. You know, are you doing it purely because, you know, you want to have intercourse, or are you doing it because we need to maintain the health of the penis so that, you know, you've got longevity and you can, you know, have intercourse at some point as well. So you've got penile rings and pumps as well. So I don't have any of that stuff with me, but the penile rings are good for people that can get an erection but can't maintain the erection. So the ring will go at the base of the penis, and that will close off or create that pressure system to prevent the blood from coming back out. And the pumps are good for people that struggle to get the erection. So it's a vacuum pump, increases blood flow to the area, then you would put the ring on to help maintain the erection. And lifestyle changes. Actually, I shouldn't jump so quickly there. So when we talk about lifestyle changes is, you know, getting people to become more physically active, looking at their diet, decreasing alcohol intake. So all those other factors, you know, that we talked about earlier, you know, can have a huge impact on recovery as well. And I did have a patient come in. He had a prostatectomy. He'd done rehab following it, and when he thought he was okay, stopped doing pelvic floor exercises, kind of did nothing. Got a new job where he was sitting a lot more, so sitting, I think it was somewhere between 8 or 9 hours a day. The job was stressful. He wasn't exercising anymore, and all of a sudden he's leaking. And so, you know, you look at those factors and, you know, lucky or not, COVID hit. He was made redundant. It allowed him to get out back walking every day. He wasn't sitting as long, and all of a sudden his leakage had improved. So, you know, the pelvic floor does not just work in isolation. So, you know, when we are being physically active and walking around, you know, you've got to have some form of tone through that pelvic floor as well. So as much as we can encourage a healthy lifestyle, we try and do it. Modifiable risk factors. So just a quick point on this slide. So when we're looking at modifiable risk factors, we're looking at you know, the amount of physical activity you're doing, you know, people's obesity or what they weigh, having a look at the diet, whether or not they smoke. So those 4 things are things that can easily be changed depending on how bad a habit is. But what this slide is saying is that those 4 things can also lead to cardiovascular disease, type 2 diabetes. Those types of conditions will decrease the amount of nitric oxide, and nitric oxide is a driving force in the blood flow to the penis to get the erection. So this is why, you know, general health becomes so important in erectile function or dysfunction. So general health, so erectile dysfunction and heart disease are closely connected, as is erectile dysfunction and diabetes. So the phenomenon is, and I just couldn't get that word out, I'm sorry, is that most people that present, or, you know, generally if people are presented with some form of erectile dysfunction, they've got some form of cardiovascular disease as well. So erectile dysfunction, yes, could be the first sign that there's something more going on or something bigger. Same with type 2 diabetes. The increase in blood sugar levels will have an impact on your vascular system. So it will, peripheral, yeah, thank you. Been talking too much. Yeah, so it will have an impact on the veins and the arteries. So then you've got that impact on blood flow. So obviously the penis has small veins and arteries. It's classified as being a periphery or a peripheral vascular system. So, you know, that's where that comes into it as well. 40% of men that are overweight will have some form of erectile dysfunction. So the stats do show if you can lose 5 to 10% of your body weight, and obviously this is in people that are overweight, then it will improve sexual function and erectile dysfunction. So, and I think too, like, you know, what comes first? Like, does the weight loss come and you become more physically active, that you start to want to be more sexually active? You know, it all works together. So, you know, you can't sort of say this on its own will have a huge change, like, because there's lots of things that changes once you start losing weight as well. The recommended amount of physical activity, so by the Australian guidelines, is this says, based on this research, it was, you know, 40 minutes of exercise, 40 minutes of moderate exercise 4 times a week will reduce the risk of cardiovascular disease and also improve erectile dysfunction. If we look at the Australian guidelines of what they recommend for the amount of exercise, they would say 150 minutes per week of moderate exercise or 75 minutes per week of vigorous exercise. So when we talk about moderate exercise, it's, you know, you should have some form of huff and puff. You shouldn't be able to maintain a conversation. So, you know, you could only get 1 or 2 words out at a time. Or vigorous exercise, you should not be able to talk at all. You've got to be working pretty hard for that. Some really good resources to take a look at, and I'll pop this slide back on at the end as well, is Healthy Male Andrology Australia and also Spanner in the Works. So they're 2 great resources. They have very easy handouts to read, directed for the patient as well. Just information, education on sexual function, erectile dysfunction, incontinence, lots of different things. So, and I think also general health as well. The Continence Foundation Australia is also a good one. So if you're looking for things on bladder or bowel health, how do you do your pelvic floor exercises, when is it recommended and things like that, Continence Australia. Those 3 websites are really easy to navigate as well. So that's why I do recommend them. The prostate recovery map and the prostate playbook. So I've got a copy of each of those here, and I particularly recommend this one to my patients that are about to have a prostatectomy, because it's written by an Australian physiotherapist and a male, which is great because I think males can resonate well with males as well, and he writes it really well, easy to read, and it's a step-by-step guide of how to improve the pelvic floor and what to expect as well. So I just get my patients to jump online and buy one of those, and it's a great resource for $15, and it's something that they can refer back to all the time. And he's also done a bit of a playbook, so it's about how to keep yourself generally healthy and minimise the risk of prostate cancer as well.
Prostate Cancer Foundation of Australia.
Oh yes, actually I should have popped that up as well. I forgot about that one, but yeah, I should have popped that up there. There are a lot of really good resources out there. The Penis Project is another good one, and I think it only just started last year, but Jo Melios, she's one of the leading physiotherapists in penile rehabilitation, pelvic health for men. She does or runs this podcast with a nurse, and they interview other health professionals, they interview patients that have been through it and what they've expected as well, and they've also got the website that goes with it. So I think podcasts are easy to listen to these days. You've got your phone with you all the time, you can pop it on in the car. It's a good way to get some information. So from today, just some of the take-home messages from me was that if I could teach you and you know now that you have a pelvic floor, then I feel like I've done my job. So speak to your friends about it as well. I think it's important for guys to know that they have a pelvic floor and it's just not their partners that have one. Erectile dysfunction might be the first clue something is amiss, so don't dismiss it. If you've got any form of erectile dysfunction, go speak to someone about it, go get it checked out. Exercise is a good thing. One, you want to keep your love muscle healthy and not just your penis. You want to keep your heart healthy. So the penis and the heart go hand in hand. So get out, exercise, enjoy the daylight, do something, because it's going to go a long way in helping you and your sexual function. And having a regular tune-up or a check-in with your doctor. So, I think they advise to check in with your doctor every 12 months. And I know it's not common for men. And I can't remember the stats of, how regular it is a guy goes to a doctor. And I only read it the other day, and it was not every 12 months. But the recommended duration is every 12 months or earlier if you've got something else going on.